You talked a little bit about some of the side effects and long-term consequences of potential of FCR with MDS and AML and the risks of those types of toxicities. What about with the BTKIs? What toxicities that we all see in common practice with ibrutinib, and we could talk about acalabrutinib as well, but you want to start about with ibrutinib, some of the toxicity profile for patients?
Yeah, I think other than the hematologic issues that we are all aware of with most of the agents that we use, I think as a class, we're beginning to discover all of these newer side effects. A lot of these side effects are unique to this class of drugs. And for example, the bleeding risk is definitely enhanced. And we see that it's an early issue that happens with a lot of the patients who get BTK inhibitors. That's then again takes us into another area. How do we manage those issues when somebody has to be on chronic, almost like an anticoagulant, for 10 years? So do they stop it when they get a colonoscopy? Do they stop it when they get a cholecystectomy? You know, there's so many lifestyle decisions that you have to make. The other thing we have all seen, and also in the kind of got the hint from the Alliance data, was this whole issues with cardiac issues, atrial fibrillation, ventricular arrhythmia, sudden cardiac deaths. Luckily, small percentages for those, but the atrial fibrillation has been an issue. And as we have all seen the real world data, because a lot of our patients have multiple comorbid conditions, they have cardiovascular issues when they start these drugs, it can be a challenging condition to manage. Also because then you have to anticoagulate a lot of those patients, or you might have to, and then you already have almost a drug that causes a bleeding diathesis. So those are challenging issues that as physicians we all need to be aware of. And the unfortunate thing right now is that there is no standard way of managing those. So it's not like you do this and it'll be fine. So I think that's a challenge that happens in a lot of our patients. The other thing that we're now studying more and more and discovering it is the risk of hypertension. I think that's a very clear risk, and that it gets worse with time, and not only just the worsening or the development of new hypertension, but the incidence of major adverse cardiac events have also shown to be increased in patients who stay on at least ibrutinib for a while. Now, whether this is a class effect or whether this is a drug effect, I think that's where the debate is right now. There are certain side effects like bleeding, for example. I think we all feel fairly comfortable that would be a class effect. Now, you might have some lower grades with one and some higher grade events with the others. That's a separate issue, but I think we all feel that the bleeding issue is a class effect. With regards to the cardiovascular issues, we frankly don't have those head-to-head comparisons and the real-world data to really comment on how that will pan out and whether that would be a class effect or a drug effect. I think it'll be a bit of both, in my opinion.
So one thing just to add to that, and I think what's really very important from both the ECOG and Alliance data, and I'm of course comparing two studies to each other, is really the impact of age on the cardiac risk. And it's certainly, you know, the hope is that we will be able to sort of risk stratify our patients for toxicities and actually choose, you know, different therapies for patients who really would need different therapies. And that was sort of what I found so interesting from the ECOG and Alliance data.
Because I think you don't see that signal on the ECOG study, and you do see a clear-cut signal on the Alliance trial, even though luckily the numbers are very small. And that takes us all back to the first point, whether we still have to stratify by age like we were doing in the chemoimmunotherapy era.
We used to do that in the future.
So I think these are all, we're back to square one about, you know, how do we sequence these and when do we use what novel therapies?
But at the end of the day, I fully agree. I think we more and more, as more agents we have available for treatment, I think we need to start to really learn how to customize therapy depending on age, comorbid conditions, risk stratification, things like that. I think we are learning as we go, right? But as you say, I mean, we may see more toxicity with certain agents as they age. So maybe the fact that other agents, perception-wise, although we don't have the comparative studies, may have less toxicity, may more amenable for younger population or not really intermediate population, while in another cases, you know, BCL2 inhibitor may be a better choice for those patients. Always we bringing back the long-term duration versus the the short term or the limited duration. And I think it's something that patients really bring into clinics and into the conversation that we have about frontline therapy. So it's multiple areas of discussions with patients these days, and more when we have really more agents available. And then I think we should really recognize that, and we should learn as we go what is the best drug for each patient.